Good morning, everyone. We're going to go ahead and get started. It's just about a minute after 8. And welcome to Grand Rounds, this very special Grand Rounds. It's really my privilege to not only introduce it, but also just give you a little bit of a background. For those of you who don't know who I am, my name is Kathy Gorman, and I'm the Executive Vice President of Patient Care Services and the Chief Operating Officer. And for the most part, I've been here for about 20 years, with a little bit of a hiatus to another hospital up north where I was the Chief Nursing Officer for about 3 or 4 years there. And so what I wanted to do, or what we wanted to do today, is talk about kind of our state of preparations around emergency preparedness. And it really gives me great privilege and pleasure to introduce our speaker today, our primary speaker, and that's Dr. Joelle Simpson, and she'll be joining me here in just a few minutes. So for those of you who do not know Dr. Simpson, who's sitting here right in front row, she's been part of our faculty for the past 5 years in the emergency department. She's highly accomplished, and she was appointed about 18 months ago as our medical director of emergency preparedness. And when we looked at, Dr. Wessel and I looked at changing the structure, strengthening that medical staff presence, and really making sure that our organization was prepared for emergencies, Joelle really floated right to the top as the right person for this role. So academically, she is on faculty at GW and teaches their emergency preparedness course there. She's a Milken Scholar, highly accomplished, and publishes routinely both nationally and internationally. She represents our institution at the American Academy of Pediatrics and the College of Emergency Physicians around emergency preparedness. So she holds those seats. She was recently nominated to sit on an exclusive high-threat emergency casualty care task force as a response to a request from the White House. So again, highly acclaimed and representing pediatrics across the country here. She also participates in the National Capital Region Planning for Pediatric Surge and Disaster Response. She manages, or she represents and leads that DC Department of Health and Medical Coalition for Pediatrics here in the city. At the same time, while she then, of course, works in her role here, she is also the Director of Emergency Medical Services for Children, State Partnerships Program here in the District of Columbia. And more importantly as well, she has led the development of an inaugural Pediatric Medical Reserve Corps for DC, which provides specialized pediatric volunteer support services for the DC community in preparation for major events. Some of those major events that we know so well, 4th of July that happens, the papal visit, and other things that recently happened, the opening of the National Museum of the African American History and Culture. And of course, she's actively planning with the city and will be helping us plan for the inauguration events as well coming up in January. So Joelle will be following me in just a couple of minutes. I also want to recognize the rest of the emergency preparedness team. We have Johnny Tolbert here, who is part of that team, has done a fantastic job. So for those of you who have stayed over with the Snowmageddon, he's the cot distributor and the cot collector, does so much more than that in terms of the coordination. In addition to that, excuse me, Jackie Forbes, who is the Director of Accreditation, Safety, and Emergency Preparedness, is the administrative arm that works so closely with Dr. Simpson and Johnny as well. So we really have a very robust team. And Marilyn, I don't know if Marilyn is here, but she's part of the team as well. So we have a whole team of people. The whole purpose of emergency preparedness is that it doesn't singularly live within one department, but cuts across the entire organization. And so therefore, every single person sitting here has a role. And we all know that when disaster strikes, it is oftentimes not it's difficult for us to lean on the federal government or even the local government, and we need to be prepared ourselves. So that's what we're going to be talking about over the next hour here. So these are the objectives that we're going to be reviewing. We're going to talk really about where we were and how foundational that has been for us over these last several years, where are we now, and where we're going. So, where were you 15 years ago and almost 15 days on 9/11? Yeah, who was with me in the boardroom when we saw the Pentagon bird? Susan was there. Dr. Martin, I think you were here or close.
Montgomery County Rock.
Montgomery County Rock. I was with Dr. Riemann, I think. There were a few others that were there in the boardroom, and this was our view from the boardroom. It really, truly was the day that forever changed the lives, not only here in the United States, but around the globe. And we all of a sudden became what we were and what we consider to be a very strong, vibrant country, to being very vulnerable to terrorism, being very vulnerable to attacks because we were attacked on our own land. So I think that we realized very quickly as a leadership team at that time how really unprepared we were for these attacks of 9/11. And although we did not receive any children that day or any patients that day, we were prepared from a mass casualty perspective, but we were not prepared generally or globally. At that time, how many of you have your little tags on that tell you how many different codes there are? Okay, almost everybody here. If you don't, Johnny can get those for you, and we'll be happy to share. We'll be happy to make sure everyone has them. We had at the time, about a decade and a half ago, 2011, about 4 different codes that we called. We call a code blue. We did have a code pink at that time. We'd call a code red, and we call a mass casualty. But after 9/11, it really changed our perspective on how ill-prepared we were for bioterrorism, how ill-prepared we were for active shooter, how ill-prepared we were for so many of these other issues that have come up. And so therefore, we really did need to change our whole approach. During that day, what we learned very actively, I know, and Lisbeth and I were talking about this the other day, number one, we tried to, one of the things you do in a mass casualty, because that's what we knew how to respond on 9/11, is that we needed to discharge our patients as quickly as possible. Well, guess what? We discharged them, but they couldn't get out because their parents couldn't get in because the entire city was shut down. We couldn't transfer patients to another hospital. We all of a sudden thought, what if we, living in a glass building, we live in a glass building, what if we were attacked, and where would we evacuate to? Where would we go? Would we go to the hospital center? Probably not, too close. Would we go to the hospital for sick children, which is right now our evacuation hospital? But where would we go? So it raised that question. We recognized that we couldn't get staff in or out, and so that we needed to be prepared to be here for at least 3 days. How many of you have 3 days prepared worth of either clothing, toiletries, and your medications in the back of your car or in your office or in your lockers? Okay, so there's a handful that are prepared. But we have to remember that that was really important, and we have to think it's not if but when, right, for the next time. We recognized that we had to manage the staff come in, and we had to really rethink on what it meant for us to be in the nation's capital and be prepared for emergencies. So since that time, we know that so much has happened around the world in the last decade and a half, and these are some of the big things that are obviously coming into front of mind. You know, our natural disasters, you know, with the Hurricane Katrina that was huge, Dr. Denise Core-Bramble actually took a mobile van down to respond to that and our response. We had an earthquake in D.C. Who would have ever thought, right? And we've had snow, and snow is actually the least of all of these. We have now organized and lone wolf terrorism that's going on all the time with these. We had a D.C. sniper years ago. There's been Sandy Hook. That was a huge tragedy for the loss of so many children. San Bernardino, the Navy Yards, and on and on. So we have to be prepared. There's a new kind of civil unrest that's happening across our country, and how we respond and are prepared for that, we have to be thinking differently. We have special infectious diseases now that we need to be prepared for that we hadn't thought about in the past. And we have, yes, our own internal disasters. So whether that be power failure and all the planning that we're doing now with our facilities team in terms of making sure we're ready and making sure our systems are maintained, to an aging building with lots of water. Okay, so we have to be prepared continuously. So what have we done over the past decade and a half, just for those who are not familiar? We have been a leader in the city, and that has been pointed out by the great work that Dr. Simpson is doing and has continued. We actually started the DC Coalition Emergency Preparedness back in 2002, right after 9/11. So we were one of the top leaders there. We have campus-wide emergency preparedness that's going on continuously. Recently, we had a very unfortunate homicide right in front of the hospital, which completely shut down our hospital, and we needed to notify our campus. So we have those campus connections where we're constantly focused, and we are internally organized to really make sure we're focused on this. In 2003, 2004, we had federally appropriated dollars to support our inpatient and ED decontamination units. Who would have thought in 2003, when we established a decontamination unit on 5 East, that in 2004, actually 15-14, that we'd be using it as a special isolation unit for rule-out Ebola patients or patients under investigation. Who would have thought? We have our ED decon unit that we have to make sure that is in continuous use as well, and readiness, continuous state of readiness. We've implemented new internal policies and procedures that are adopted nationwide, and I will tell you that for those of you who have been at other children's hospitals, not everybody takes emergency preparedness to the same degree that we do. Part of it is because of where they live in their area, but also because they're not thinking about it in the same context. So our policies and procedures have been shared nationwide. And we have, you know, after 9/11, one of the things we did, you may ask, gosh, why do our families have to stand in those really long lines to check in? Well, that was all as a result to say we needed tighter security, we need to know who's in our building, and we need to be able to manage that. So a lot has happened. Over more recent years, I think over the last 3 years, we've kind of seen these new and emerging threats that have come forward. So we've really had to reevaluate our program, and that's when we move forward with a new structure. The structure is that Dr. Wessel and I, working with Dr. Cora Bramble, lead the emergency preparedness work, so it's a collaborative across the organization. It reports up to Dr. Shaw and up to Lisbeth Fahey in terms of the overall program, so that we ensure this system-wide aspect. And we've continuously reevaluated our program in terms of the new and emerging threats. And one of those threats that Joelle will talk about in a minute is even things we don't think about, such as cybersecurity and what that can do to an organization as well. So this is your audience. Pull your iPhones out or your smartphones, okay? And you're going to go here. You're going to go to pollev.com/Moulton. And I want you to answer these questions. I'll give you that in a minute. What worries you most? Yep, sure. Emerging infectious disease, mass casualty, terrorism, active shooter, weather emergency, cyber. And here's your address. And the address is right at the top there. And you can do this online if you're on WebEx as well. Okay, we still have responses coming in, but the majority of the individuals in this audience are worried about active shooter. And yes, and Joelle is going to talk a little bit about what we've done to plan for active shooter. It is very real. It is very real. We've had real drills with active shooter, and what are the things that you all can do to make sure you're protected and protecting our patients and families here. So with that, I'm going to turn it over to Dr. Simpson, and just, as we think about this, by failing to prepare, you're preparing to fail. So we have to be in a continuous state of readiness all the time, and Dr. Simpson's going to talk with us about how we're doing that. Thank you.
Thank you. All right, so that was pretty interesting, that poll on what you consider disaster, or what you consider to be the biggest threat facing our institution or ourselves at this point. I want to move forward because it's obvious we all have a different sense of what a disaster is, either based on our own personal experiences, where we live, and the risks based on our community. This is the most recent review of events. So, this issue is real. It's present. It's in the news. Just this past summer, we've had everything from mass shootings to acts of terrorism, active shooters, including the bombing in New York. And how do you even start in terms of emergency preparedness to know where do you put your resources first? Where do you even start to get an institution ready for dealing with issues should it come to our facility? And then we have these pesky mosquitoes. So Zika has also been on our minds. So not only are there the news-breaking events that happen intermittently throughout the day, or throughout the weeks, but also there's this ongoing issue of Zika and the impact that can have on our country and certainly on children moving forward. So these are all active issues that we've been dealing with from the emergency preparedness standpoint, and this is how we tackle it. So when we approach emergency preparedness, we think of the disaster preparedness point of it, which is preparation and dealing with the issues around mitigation and trying to prevent the worst possible outcomes due to a disaster. And then we think about the emergency management end. So that would be, how do we best have a response, and how do we deal with the potential for set ourselves up best for recovery? So of all the issues in the middle, these are the ways that we tackle how we do our skills training and how we do our drills for the institution. Here's an example of how we prepared, for instance, for Ebola. And as Kathy mentioned, we are one of the pivotal institutions, especially pediatric institutions, that tackled Ebola with our response task force back in 2014, and was pretty groundbreaking in terms of the multidisciplinary approach to our response. Dr. DiBiase and Dr. Sung from infectious disease and infection control led a team that not only worked within those departments, but across, I can show you here, our transport team and our emergency department nurses that were able to use the special isolation protocols to get a patient from the field into our emergency department and up to our special unit. This is our transport team that retrofitted our ambulances in order to be safe and secure, but also patient-friendly with paintings for any Ebola patients that we had. So these were very, very minute level details that we went into to provide the best possible care for a very significant event. And a lot of the lessons learned from this exercise were shared across the country and were published by Dr. DiBiase, and were recognized by the Center for Disease Control and the American Academy of Pediatrics and on the federal level. We were also recognized internationally, and of course the work from Sarah Birch and Linda Talley here were able to bring a group of Japanese nursing trainees from Japan who were able to see some of the best practices that we do employ here for emergency preparedness, and were able to take those lessons back to Japan and to be integrated into their training. So we're not only being a model for our country, but we're definitely showing the world how to do this best. This is an example on a more local level. So our neonatal ICU, you may have seen in the news recently, Pseudomonas was unfortunately found in the NICU at Prince George's Hospital. And this is what we do. We support each other across the hospital system within the area. And being the large children's hospital that we are, we were able to support this institution in being able to transfer to a local surge event of sorts their NICU patients using our transport team, our infectious disease team, and our NICU to best respond to this emergency that occurred. And this is something that we are concerned about and plan for, not just in receiving patients from another institution that needs help, but also what happens when we need help and we need to also transfer our patients to another institution. So the collaboration that we've been able to build locally, especially through the DC Emergency Healthcare Coalition and with our Maryland and Virginia partners, has been valuable. So our response there was great. We have another example here, and this is more so dealing with recovery and mitigation. Zika. Zika hasn't even hit DC yet, thank goodness. But we are ready. So we are leading the congenital Zika virus program here. That has also gotten recognition from the CDC and on a national level. And what we have prepared here is a multidisciplinary approach to dealing with any patient that is suspected to have Zika. So we have been working, and this is weekly meetings with radiology, our fetal medicine program, infectious disease, pathology, and PR and marketing, in order to come up with the best approach to handle phone calls, patient visits, and all of the concerns of a potential pregnant mother or a baby that's been diagnosed with Zika. So while not all of us in the room may be touched immediately by these events, I want you to know that Children's National has been something you can be proud of in terms of taking the lead on issues such as this and tackling these emergency preparedness topics. So I'm going to take a 30,000-foot view for a little bit to talk about where does our approach start from a national level, our support, and then moving down to the nitty-gritty of our institution. So when a disaster occurs on a national level, there's a cascade of events that occurs, including FEMA, including the president, and then eventually trickling down to a local response that's divided into specific functions. These emergency support functions is how our city approaches emergencies on a day-to-day basis. So all of these players are involved, and the part that we play, ESF 8 as it's called, is health and medical. So this is where all the hospitals come together, the skilled nursing facilities, the dialysis centers of DC, and we meet on a regular basis to talk about the same issues that you were just told about in terms of emergencies, and how do we best protect the citizens of DC and the surrounding areas. We also have regulations. So not only a format, but we have regulations that have come down. Most recently, the Center for Medicare and Medicaid Services have implemented some standards, but we also follow regulations and screening from the Department of Health, and we all are aware of Joint Commission. So I was looking at the new CMS rule that just came down, and this is scheduled to be implemented by November of 2017. And it says we need to develop an emergency plan for all institutions. We need to establish related policies and procedures. We need to create a communication plan, and we need to devise training and testing programs. And I looked at this, and I thought, that's exactly what the job description said for our Safety and Emergency Management Committee, not to mention my own job itself. We have already been doing these things. So I'm very proud to say that essentially we're ready for the Center for Medicaid and Medicare Services. But in terms of our approach, we do our daily emergencies well. The emergency department team here knows that we see high volumes of patients, the highest volume of patients in the area. And we do the best for each individual. That's been our day-to-day approach. When we think about preparing for disasters, we want to do the greatest good for the maximum number of people to maximize survival. So in terms of our approach from the Safety and Emergency Management Committee to do that best with our colleagues, we've thought about where do we start. So similar to the poll that I gave you, that you got earlier, we list a set of disasters or potential crises that we would be concerned about in this column. So those are labeled the events. We think about the impact of or the severity of those potential disasters. So this is measured in terms of human impact, property impact, or business impact. We then think about what are the things that we've done to mitigate those impacts. So what is our degree of preparedness, what is our internal response, and what is our external response? And this we all use to determine the severity of each hazard that you listed before. When we think about those hazards, we estimate the risk of those hazards, which is equal to the probability of these events occurring, multiplied by the severity which we would have calculated. And this is called our hazard vulnerability analysis. This is how we come up with what our top list of priorities are in terms of approaching disaster preparedness for our institution. So we do want to tackle everything at once, but of course there needs to be a systematic approach. What we've come up with from our institution is that we are concerned about internal floods. There's a high risk of there being significant damage to our property if that were to occur. We've also had a great number of events that have been impacted by the blizzard, whether it's to our business function or even to our personnel. And of course, as you guys all alluded to in the survey, mass casualty is always a concern, as well as emerging infectious diseases. So this is a little bit of the history of what we have faced recently. These have been the federally declared disasters in DC in the past decade. And all of our thunderstorms, Hurricane Sandy, or our winter storm most recently have all been federally declared disasters by FEMA and by the President. We also had the earthquake of 2011. And while our West Coast colleagues may scoff at us, we still did learn a lot of lessons from our earthquake. And so, as Kathy mentioned, we are a glass building, and we did realize that while everybody may have wanted to run out of the building, certainly being a glass building, that puts you at much higher risk, and the safest thing is to stay in our facility. So we learned lessons from every sort of event that's come about. Winter Storm Jonas was truly a pivotal moment for us. A lot of us stayed here many days. I know I was the ER doc for that weekend as well. But we were fortunate to have a leadership team that was able to take us through this process, especially with Joe Talley at the helm, and a lot of our nursing staff that rallied through in terms of being able to provide care for our patients during that time. I have a question for you, though. There were a lot of people behind the scenes that did do a lot of work to support our staff and our patients during that time. And one of those folks were the people in food and nutrition. How many meals do you think were served from our cafeteria during the winter storm? I want you to enter the poll. Go to polllab.com/modlin. And do you think it was 1,500, which is our normal average, 3,000, 5,000, 8,000, or 1 million meals? Who said 1 million? So the poll is neck and neck, 5 and 8. The answer is actually 8,000. So we served an enormous amount of meals, and that took a lot of planning and preparation. We don't necessarily have 8,000 meals just sitting here in our cafeteria. So we really do owe and give a lot of credit to our food and nutrition team for supporting us during that time, but also safety, security, environmental service. These are all people on our Safety and Emergency Management Committee that help in the planning process to prepare our institution for dealing with those threats. So my take home for you is to realize that emergency preparedness is a team effort. Yes, I may be medical director of emergency preparedness, but none of this is done alone. No project can be successful without the work of all the different team players here. And, you know, I highlight the emergency department, certainly on the front lines for any mass casualty or active shooter and so forth. Our residents play a key role as you guys spread across the institution. Our outpatient centers are especially vulnerable, but they certainly receive the community response to any type of disaster. And so there's a reason for us all to be prepared and acknowledge the plans that we've put into place in order to best serve our community. So there's a system-wide way to approach this. As with any team, there's a coach, there's the assistant coach, and there's a way to approach this. I don't know if any of you have ever heard of the National Disaster Medical System, but this is the way our disaster team is set up, and this is how it's set up across institutions. So there's an incident commander, which is the lead role that's assigned whenever a disaster hits, whenever a code is called in terms of a disaster. That's usually the administrator on call for the hospital, but they have a ready to-go staff that supports them, including pre-designated roles, and these are actual vests and actual job descriptions that folks have here and assigned in our institution, as well as section chiefs. And these are people that do the operations, the planning, the logistics, and the finance for dealing with any sort of disaster that hits our institution. And I would say if you work here or if you work at any other hospital, this is the model that you would see in terms of disaster preparedness across the country. So incident command is set up, and they know to meet in a specific area. That's where we ask for help whenever your department is hit with an issue or if there's a hospital-wide concern. Where do you all know incident command to be located in our hospital? Where do you go as a staff member if you wish to volunteer if there's a threat to our institution? Are we in incident command right now? So the polls tell the truth. It is the Bear Institute. So that's where incident command is established. And if there's a threat to the Bear Institute, we also have a system of setting up a virtual incident command center if need be. So rest assured that there is an organized system. And yeah, just like the 1 million person. There's always one of those in every crowd. But So rest assured that there is a systematic approach to any disaster that we do face here, and there are our leaders and our leadership for the hospital that are trained and experienced with knowing how to approach this in the way that's recommended across the country. These are our priorities for the upcoming year. So these are the things that, as an institution, that we want to focus on improving and being the best at over the next year. So it includes shelter-in-place and evacuation drills, mass casualty drills, surge planning, and that's for patient surge, or emerging infectious disease management. I've talked a lot about some of the examples of the ways we've approached emerging infectious diseases. I want to talk about our approach to some of the others. So we've been very fortunate already to have quite a few evacuation drills. Some of you that work at the different units know that Johnny and I have had our road show coming to each of the units, as well as Jackie. And we've already worked with NICU, neuroscience, HEMONC, 7 East, CICU, surgical care, PICU, and Anne Arundel especially. We've been out to their outpatient center and a few others to go through evacuation drills. And here's an example of med sled training, which is a quick evacuation process for taking care of patients and getting them out of either their unit or the institution as fast as possible. On a citywide level, people are always concerned. We are a high-profile city, certainly quite a target in many ways. This district has been dealing with this. So we do attend monthly meetings that are with the other hospitals and the Department of Health and the Agency for Emergency Preparedness here in D.C., where we do have a mass trauma plan workshop that's been being worked on. But we've also implemented things in our institution to best deal with a mass casualty, and that includes our ad hoc crisis communication system, which many of you may have heard or gotten alerts from when we've had a code orange or a mass casualty. And this is a system that allows us to connect to your personal devices as well as work devices so that you're all aware, no matter where you are, about the threats that are facing the institution or the city. We should be extremely proud that we have one of the sort of state-of-the-art emergency communication and information center. The folks that work in what we fondly call in the ER ECIC are specialists that are able to intake all of the emergency medical services information from Maryland, D.C., and Virginia. There's a constant news headline and updates and weather updates that are going on there, so any crisis that hits the area or the region, we're immediately alerted. They manage a lot of the intake and communication also for the local hospitals. So there's a lot of pride we should have in this system that we have housed in our own institution. Lastly, we also have our healthcare information system, which is an online network that's shared among all the hospitals. So in case of a crisis, if, for instance, we did have to evacuate our NICU patients and we needed to know what regional hospitals have the ability to take NICU beds, or if we, for some reason, had a shortage of ventilators, this is where we would post information that is available to other hospitals, so we know how we can share personnel, things, know if we need space, if we need to transfer patients. So in any time a disaster hits, our nursing administrators on call or administrative directors, they're able to go in there and say, we have 300 patients in the hospital right now. We have 100 patients in the hospital right now. We have the capacity to take the really, really sick patients, the not so sick patients, or what we call red patients, yellow patients, green patients. So this is great. We have a very robust and up-to-date and active way to integrate with the rest of the city to best care for our patients. We did some drills. This year in 2016, we were debriefing here after a large mass casualty drill where we simulated having a response to many injured pediatric patients to the facility, and see how many departments were involved in this drill. We had the trauma surgeons, emergency department, respiratory therapists, registration, radiology, child life, social workers, security, a lot of people that were a part to play, and we realized even more that needed to be at the table, and those were some of the lessons learned in order to best take care of the patients when they come for a mass casualty. And this was an excellent example of teams coming together, and you always think that this is, we have a lot to do on a day-to-day basis, but the lessons learned from this are so valuable. This took within an hour. We were able to successfully perform this, especially with the help of the simulation center, and hope to do this on a more often basis moving forward. So we appreciate your support in, when you hear those alerts and we have a drill, understanding your part and your role to play in Code Oranges and all of the codes. I talked about the different phases, and one of the other phases, not just in preparation and response, but is also recovery. So what do we do with our patients after the event has occurred, after 9/11? And certainly there's questions from our children and our patients. These are some of the resources that we've developed, and specifically from Dr. Joshi, who's an international leader on the behavioral health response of children in disasters, and has come up with these resources that you can use in your clinics with your patients, or even for your own families when children ask questions about these disasters, and you want to know some of the ways to approach dealing with the issues of terrorism that we unfortunately have to talk to our children about nowadays. So we should be proud that we've taken the lead on dealing with some of these issues and tackling it and offering it as a resource nationally and internationally. So these are some of the things that we ask of you today. We want you to make a personal preparedness plan for you and your family, because we know that in order for you to serve here at Children's National and to serve our patients, you need to be ready at home. It doesn't help if you don't know where your kids are. It doesn't help if you don't know if the daycare knows what to do if a disaster hits. Educate your patients on personal preparedness. Enroll in the ad hoc system so you're aware when something happens, and know your role in emergency codes. Here's an example of a personal preparedness. I endorse this one. It's from the American Academy of Pediatrics. It's the most recently updated template of how you create a personal preparedness plan, and there's the website. In it, it talks about how do you, the recommendations on how you become familiar with your child's school, or even helping your child's school or daycare develop a disaster plan, how you plan for your family members with special needs, how you plan for your pets when there's a disaster, and how you create a disaster supplies kit. So just as Kathy mentioned, and having a 3-day supply of your medications, clothing, food, water, those are all important in order for your family to best get through a disaster. What can you do to help your patients? So similar thing. Share with them the information about the preparedness plan, but also there's a system, I don't know if many of you are aware of, Smart 911. This is a system that's used by the DC Fire and Emergency Medical Services department, and what it is you're able to input data about yourself or your child regarding medical conditions, special needs, etc. It goes into a Smart 911 database, and whenever you call 911, give them the address or you give them their phone number, that immediate information gets pulled up, almost like a patient's chart, with all of the relevant information for them to know what your child or yourself is dealing with so that they have that ready information. And working with the EMS system in an emergency, it's really a lot more helpful for them to have that on their mobile devices entering a house than waiting to try and get that history in a crisis. So certainly these are ways to help in a disaster at smart911.com, and I encourage you to share that with your family members and also with your patients. Lastly, I mentioned over and over again how important it is to sign up for our ad hoc system, so that we're able to get alerts appropriately, whether there's a disaster and whether there's a code, so you know that if you have a role, how to respond to the hospital, and know where the codes are. So everybody should be aware that the codes are on the intranet. You go to the intranet under Department, Facilities, and go to Facilities and Operations, and then there's the Safety and Emergency Management team. I want to take a minute to give a shout out to the Anne Arundel Outpatient Center. They specifically emailed us and said, hey, we're worried about an active shooter. We're worried about stressed out parents who may come and make threats to our institution, to our office. We'd like you guys to come out. So we took Tim, one of our the leaders in our security department. We went over there. We did an assessment. We talked about cameras. We talked about panic buttons. We talked about the glass door to their facility. And they were able to run through what would we do in a disaster if we had a threat such as that to our institution. So yes, my office is at Michigan Avenue, but we care about this system-wide, and we encourage you to reach out to us at emergency preparedness at childrensnational.org in order to solicit that sort of help from our team. Extra credit. So Kathy talked about the Pediatric Medical Reserve Corps. This is an organization I'm extremely proud of. We have a very robust team that works on it. This is a request from the DC Department of Health, who had been at a number of public events and mass gatherings where children were having injuries or issues that folks at the, honestly, at the medical aid tents weren't able to deal with and weren't comfortable with. So they said, would you be able to find any pediatric personnel that would help us staff these events? as we talked through it, we realized the model of Medical Reserve Corps seemed most appropriate. The Medical Reserve Corps model came about after 9/11, and it was a way for medical volunteers to be organized systematically to understand beforehand all of the issues I've already talked about, what incident command is, what the organization of a national disaster system should be. And they were ways for us to staff on the front lines with people that were not necessarily in the hospital but had medical training to care for any sort of victims in the community. We're fortunate to be the first model of a pediatric medical reserve corps in the country. We did a lot of research to see if such a model existed, and our first example in volunteering was at the papal visit, where there was a child with special needs who had seizures, who wanted to be blessed by the Pope, and the family wanted him to stay there. But of course, our team was able to help assess him and actually be able to have him stay at the event on the front lines, realizing he did not need to come into the hospital, and was a great resource for that family in the community. We've also been able to have some support we provided at the 4th of July event and recently at the National Museum of African American History and Culture. And our roles are not just clinical. This is not just for the ER doc or the ER nurse. We've had people here. This is one of our administrative folks that works for the EMS for Children's program, and he was able to help with reunification and tracking of patients. And these are things that we train for disaster events so that we can best serve the children that come to attend these events. And certainly the inauguration has been another one we have coming up. We also have collaborated with the DC Fire and Emergency Medical Services to provide a pediatric disaster training course. It's a 2-day course that offers 16 credits of continuing education credits. We offered it last year right here in this auditorium last November, and we're offering it again this year to help train both with our colleagues but also with EMS. We've had medical students, we've had residents attend this course to understand a little bit more about the nuts and bolts of a pediatric response in a disaster. One of the lessons learned going across the country and even working within DC is that we have a lot of folks out there who do work on the front lines but not comfortable with children. So the more that we have our expertise on the front lines, the better we feel that is for our children. The contact is one of our nurses in emergency department who works closely with EMS and on emergency preparedness issues, Emily DeRose, and you can email her if you're interested in registering for that course. So this is our call to action. The power of preparedness, as I've talked about on an international level, national level, what we've done at the citywide, and then what we're doing in our institution and what we can provide for our community. I ask you to create this action list. So create an emergency plan for you and your family. Meet with your department leadership. Talk about either a plan, scheduling a drill, signing up all of your staff members for ad hoc, educating your patients. I say at least 10 patients in the next month, at least have a discussion about emergency preparedness and things that they can do to be better prepared in a disaster. And review your emergency codes. One suggestion we have is every staff meeting, spend 5 minutes just talking about one of the codes. There's not that many, but it would be best to talk about it now than in the moment. And certainly that's one of the ways we hope to get our institution better prepared. It pretty much summarizes everything I wanted to share about what we've been doing. We talked about our past, some of our successes right now, and where we want to move forward for the future. I want to open the floor to questions, and Kathy can join me if you have any questions about emergency preparedness, but also offer this resource if you have any follow-up that you'd like for your institution, for your department or your unit regarding emergency preparedness topics. Thank you.
Joelle, thank you so much. That was very, very informative for us all. What kind of questions does the audience have?
Kathy, Joelle, I just think it's amazing, this work, and I think the word preparedness is the one that really resonated with me and planning. And I just wondered, so much of the planning and preparedness is about leadership and a system of leadership, who's in charge, who's organizing the response in real time. And when I think about that, I think we're really well prepared to do that kind of, to be honest, Monday through Friday, 8 p.m. to 8 a.m. to 6 p.m. kind of a thing. I've always worried a lot about off hours. The Justin Bieber concert on Friday night is the one that always just kind of has always worried me because of the for so many levels. Yeah, but the right, but you know, the absence of leadership on site during those times has always really worried me. There are actually a lot of staff members here Friday night at 9 p.m. But what do we do about leadership at that time?
So, Dr. Teef, it's a great question, and let me tell you a few things that we do. So, real life example. Last Thursday morning at 4 o'clock, 4:15, I got a call from the administrator on call, Mary Damont, to say we had a water break in the 5th floor research that had flooded out the research and had gone into the adolescent psychiatric unit, and that we needed to, you know, respond. The AD is here, and that is the person who off-site is here monitoring any and all activities. They then escalate up to the administrator on-call team. Mary and Joe Talley, who happened to be on, both came in and were here within probably an hour or so to manage that, and then Dr. Bachow actually was in as well. So that is one real-life example of how that happens. So we have a really strong administrator on-call team. Over the last 3 years, what we've done is we've also created an administrator on-call backup, and we're training those individuals. So on about every other month basis, we have AOC, I call it a lunch and learn, and I actually lead that, and we talk about real-life either disasters, patient situations. So this Friday we're meeting, we're going to be talking about the aggressive patient. How do we manage that as a leader? If that gets escalated, how do we manage with disasters? So I think that the culture of our leadership and being present and making sure that we can respond and be here has really, really changed, and certainly that is the expectation of Dr. Newman. So I don't know, those are things that we're doing to really make that change and transition. Is that helpful? Okay, great. Dr. Robb.
It was great that you went out to Annapolis, but some of us are in shared facilities outside the hospital, so the best is 3023 Henniker Court. And sometimes patients on the PSV side will be out of control, and what's our role? There's no security there. They've had violent patients, and they've had to call the police and hope the police will come, and, you know, it takes a while, and people are at risk. And what's the planning between the two institutions to handle, especially violence, I think, is the big issue.
So we're happy to come out and discuss the unique institutions or the unique facilities that exist within the institution. I know that our security team is here, and they've said repeatedly that we will come out and assess and see what we can even add to make it a little bit more secure. But each hub of our system has its own unique needs. So we're happy to respond to that and can come out.
So, and that is one of the areas, Dr. Robb, that we're going to be also strengthening. We recognized it with one of our active shooter drills that we did, and also I think it was about 6 months ago there was an active shooter in Montgomery County. And so we said, how do we need to strengthen our extended campuses response? What we say now is that the extended campuses do need to rely on 911. That is the process we have in place and what we've had in place. However, how can we connect them a little bit more? One of the things that we recognized, Paul Ruskowski, our Director of Security, is implementing a new security system, camera system right now. So it's prioritized for capital. And so those cameras are being placed in some of those extended campuses so there can be monitoring on the main campus. So we're making some strides. We're not where we need to be yet. Great question.
Excellent talk, and thanks, Kathy. Thanks, Dr. Simpson, for helping us put this in perspective. But I also want to add to what Dr. Robb just said, or maybe you can answer it as a question. I know that you have focused a lot on the inpatient services. What about the clinics? Have we gone out to the clinics? Are you going out to the Are you going to come to pulmonary clinic and give us some tips on what to do? Because I think most of the focus I've seen is for us to come to you, come to those preparedness, the drills and all of that. But when you're on the front line, when there's a clinic running, I think it would help if you came to us to give us some tips on how to respond.
So that's why I highlighted the emergency management and emergency preparedness intranet link. On there, it shows examples of different drills that we can come out to the different clinics to give, whether it's training on med sled, so for immediate evacuation of clinic patients, or if it's an assessment of the clinic to see where would be the best evacuation route or the best way to systematically approach getting staff out or to protect the staff. And so if you go to this email, just let us know, for instance, what we've done for the inpatient units is attend their staff meetings. We can come in and we have a presentation all ready to give where we do a needs assessment of the different areas, and then we follow up with another visit where we do functional exercise, and then we can do real scale drills. So we're happy to do that. Just reach out to us at this email, and we can schedule some time with your clinic.
I do have, I was going to have a follow-up comment to that. Thank you, Joelle. Excellent presentation. The point that is raised is a valid one, and I want to see how we can coordinate the effort so we can look at all of the ambulatory facilities and figure out some sort of strategy, as opposed to having them each reach out to you individually after they look at the website and all that. So I think that I'd like to work together with you so that we can come up with a plan.
Absolutely.
We have one more question here, and then Dr. Ratney. Go ahead.
I want to thank Safety and Emergency Management. I wanted to thank Safety and Emergency Management for their support, because we've actively been working in the OR to improve our preparedness. But I would just want to raise one issue that has come up in some of our conversations that may not be under our control, but it's just communication from first responders and EMS. Recently in a mass casualty, we had some miscommunication, which, again, since we're receiving communication from them, but since we're part of the coalition, I don't know if that can be brought up in.
Yeah, so one of my roles, I work on the Mayor's Advisory Committee for EMS for DC. We've been working very actively with EMS leadership. In fact, we had a meeting with Dr. Newman, Dr. Cora Bramble, and the medical director for the local EMS units here to talk about an approach to better prepare them, both in communication of what our needs are and what we can provide for them. So that's why we're doing that shared training on pediatric disaster preparedness at their training facilities, so at the EMS facility. And we do provide trainings for their providers to understand some of the nuances of pediatric care so they can best communicate that when they're coming in with the patient. But we have a long way to go, yes.
I also wanted to just mention before Dr. Ratney asks your question next, is that not only have we been working with EMS, we've been also working over the course of the summer with the Metropolitan Police Department. As many of you know, we had a special Grand Round series this summer around care of the aggressive patient, the challenges that presents. And we recently had a big a group from the MPD that came in and shared what they're doing on the front lines as well. The other thing is, you may recall that we now have in the emergency department around active shooter and our collaboration with the city, right? Not only through the core, but also then through our other partnerships, is that we have a Metropolitan Police person who is armed. So we have an armed guard sitting in the emergency department. Now, that was a very strategic and high level of discussion with our leadership and board before we did that about 2 years ago. But we felt that that was really critical because they have the direct access that we need right to MPD. So Paul and Tim helped to manage that with Martha, and really, really important. So those collaborations are critical, and when they're not working, we now have direct lines to make sure they're working. So great question. Angela?
Thank you guys both for just such a wonderful talk. And emergency preparedness is something that I agree we each play an important role. Just a quick comment and then maybe a question for you guys. We as critical care attendings actually do go to Walter Reed National Navy Medical Center. So I've been attending there for 12 years. They, through the military system, provide us with a great deal of training. It's online learning. They don't have us go through practical drills, but there is a lot that can be learned from their cyber awareness and their training. One of the most important things that I would ask your team, if you're looking at I think about the first responders, and as we've heard in the outpatient clinics, recognition of a danger, that sort of either gut instinct or recognition of a threat, I think is, you don't want to be hypervigilant, but certainly if you hear something, say something. So they have attached to each phone a drill of who to call, what to say you heard, or what you saw. And so I think my question to you guys is, for escalation, internally, when we do have an aggressive parent or an aggressive patient, I'm more alarmed hearing that individuals have talked to someone about it, but they haven't followed a process. And I think for internal communication, as you mentioned, the ADs seem to be a pivotal point, but I wondered if we could be educated as first responders on something as simple as how to speak about a concern for an aggressive patient, how the rocks might actually address that and raise the attention so that you get not only a level of activity, but that the individual really handles it in a secure manner, hoping to de-escalate a situation or at least identify a threat. So your comment about first responder training in terms of threats and how they should announce that to you guys.
So that's a great question, and there's a group right now actively working on that very issue. So Linda Talley, Martha Para, Dr. Shaw, they're working on that process around creating a behavioral response team similar to our CAT, our clinical assessment team. And so we're working on that escalation piece, but it's absolutely a great question. We are primarily focused on the inpatient, so we'll be looking at the ambulatory space as well. And now with Denise stepping in to partner on that, that's fabulous. That's great. So this has been a great conversation, and ideas, lots of activities, or lots of things for us to follow up on.
Kathy and Joelle, great presentation. You know, I'm always amazed at the Washington, D.C., very multicultural, and our population from many different backgrounds. And I'm wondering, as we're looking at emergency responses, about how we really prepare so that we can communicate with families who are non-English speaking, and how we do that in a just-in-time way and how we prepare for that. So it's just really a comment about making sure that we're thinking about that for those patients who may not be able to understand what's happening.
Absolutely. I also encourage using Smart 911 for those reasons, because there are a lot of our multilingual patients that have complex medical needs, and that's a way to sort of have them ready, set in a database, so when EMS responds, we have an idea. But certainly it's a discussion that's come up on the EMS and the front lines in our meetings for disaster preparedness as well. And we have an upcoming DC Disaster Task Force meeting, and I will bring that up again.
Great.